So everybody can see my screen.
Yeah.
So my name is Saima Ahmad. I'm interventional neuroradiologist in Lahore General Hospital, and I'm going to talk about the vascular anatomy and the intracranial aneurysms. So this is the brief outline of my lecture. I'll be talking about the arterial system, venous system, and about the aneurysms. So I want all of you guys to have one thing in your mind, that we are talking about the angiographic anatomy. So I'll show you the angiographic views all the time. So this is one of the reference book, and this book, I like it very much. This is by the Pierre Lestunias and Barenstein, and I'm sure all of you, or most of you, have all the 3 volumes in your shelves, because I have 3. I always go back to these 3 books whenever I need something. So these are very good books. So before I start my formal lecture, a quick review of the imaging technique which we are using these days. So we use the fluoroscopic X-ray, which is the energy source of these angiographic views. And then we use the iodinated contrast material. Iodinated contrast material has the ability to detect the flow of the movements within the vascular system. Then we use the digital subtraction. Digital subtraction is actually, this is a still shot. We take the still shot, and with the help of the computer, you do the subtraction pixel by pixel. And by the end of the day, you got the digital subtraction image. Then we use the road mapping during the angiographic, in which we develop the pathway for the navigation of the distal navigation of the catheters. And a few words about the projections. So these are the projections we will talk about in the next few slides. So we have 2 tubes in the neuroangiographic suite in the machine which we use for the neurointerventional work. There is a frontal tube and there is a lateral tube. With the frontal tube, you take the AP projections with the towns and the water submental. So for the different arteries, you take different projection. With a pure AP projection is best for the posterior cerebral arteries. Down view is best for, for the vertebro-basilar systems. And with the lateral tube, you take the true lateral angiograms. And another views are the right anterior oblique and the left anterior oblique. When you want to see the bifurcation, you always do the anterior oblique views. If on the right side, then the right anterior oblique, then the left side of then left anterior oblique, because the carotid bifurcation is mostly visualized on these images. And then we have 3D rotational angiogram. 3D rotational angiogram is actually a scout view. So you take the 120 images, and then you on the scout view, and then by the post-processing and by the subtraction, you made the beautiful 3D angiogram. So this is one of the 3D angiogram, which I have taken from my own data. So this is a very beautiful picture, and you can see that there is a vertebro-basilar junction aneurysm along with the fenestration. So these kind of the images you can obtain by the 3D rotational angiogram. So our arterial system, it starts with the aortic arch. So these are very simple kind of the images which I have drawn myself for you. So quickly we go through through it. So we start from the right side. On the right side, there is a brachiocephalic trunk, and then we have the right vertebral artery from the superior aspect of the subclavian one, and then the left common carotid artery, and then the left vertebral artery. Now, the left vertebral artery, it may arises directly from the aortic arch or from the subclavian artery. And there are 2 other important trunks, which are the thoracocervical and the costocervical trunks. The reason I am talking about these trunks is this, that they have ascending and the deep cervical arteries, which make the anastomosis with the vertebral artery. And whenever we are performing any kind of the neuroendovascular procedures in this territory, we must aware that these trunks give certain branches which have the anastomosis with the vertebral artery. So this is the diagnostic catheter. And when we start our angiogram, we have to select each artery and then take the angiogram. So this is the right vertebral artery. Then we select this artery and take the angiogram, and then into the right common carotid artery, and then into the left one, and then into the left vertebral artery. So the conventional angiogram have these 2 ICA angiograms and the both vertebral angiograms. This is again the same, which I have described earlier, and this is next is the angiographic view, and you can see the aortic arch and the rest of the trunks, which I have explained earlier. And there are many variants of the aortic arch. I'm not going to go through all those variants because for me that is not important. You must be aware of one single variant which is very common, and which is the bovine arch. In the bovine arch, instead from the right, instead from the right side, the left common carotid artery is arising from the right side. So this is a great problem during the navigation, because you can see the diagnostic catheter, it has to take a lot of the curves and to go into to select into the left common carotid artery, and there is always a problem. And by the way, I don't know why they name it as a bovine, maybe due to these two horns, or I don't know. So we start with the common carotid artery. So the cervical, the first is the cervical segment of the common carotid artery. So this is the lateral and the AP projection of the common carotid artery. And I told you earlier that we have to be specific about the projections which we are going to see. So for the common carotid artery, we want to see the bifurcation. For the bifurcation, the best view is the right anterior oblique and the left anterior oblique. If on the left side, then the left anterior oblique. Then if on the right side, then the right anterior oblique. So the anatomically, the direction is this, that it is posterior and then the lateral. So this is the internal carotid artery, and this is the external carotid artery. Internal carotid artery never give any branch in the cervical segment at the bifurcation level. However, the external carotid artery give a lot of the branches which are arising from the trunk. So the first couple of the 2 centimeters of the internal carotid artery, internal carotid artery are the, this part is the carotid bulb, and it has a lot of the baroreceptors. And if we want to see the carotid stenosis, then we always have to measure the caliber distal to this carotid bulb. So this is the point where there is a lot of the pressure and there is a shear wall stress. So mostly the thyrosclerotic changes we see here at this level. So sometimes the ascending pharyngeal artery arises from this point, and which can be mistaken as the branch of the carotid artery, but it's the one of the ascending pharyngeal artery, which is the branch of the EC. So again, the anatomical direction of the ICA and the ECA. So this is subtracted, unsubtracted, subtracted, and then the unsubtracted view of bifurcations. And you can see again that the bifurcation is at the level of the C3 and C4. It is the commonest bifurcation point. We can have the low bifurcation and upper bifurcation, but the commonest point is C3 and C4. And again, in the cervical segment, you see there are the different branches arising from the ECA, but no branch from the ICA. So next we talk about the nomenclature and the anatomical segments of the internal carotid artery. This is a very simple kind of the diagram which I made for you guys to understand the segments. So the first we start with the cervical segment. Cervical segment is from the bifurcation up to the neck and skull base, and here it enters into the petrous part. The petrous part is the bony part, and first it's the vertical and then the horizontal part, and then the third part is the cavernous part. Now the cavernous part is it has 2 parts. First, the small part is in the bony, and then it's in the within the cavernous sinus. So the cavernous segment is a very important segment because it lies within the artery lies within the vein. So within the cavernous sinus, we have the cavernous venous plexus, and these are those plexus when the trauma occurs and that result in the CC fistula. So from here, the internal carotid artery exits, and this is a very small part which is yet not intradural, and it is still the extradural part, and this is the ophthalmic artery. So the ophthalmic artery is actually the dividing landmark between the intradural and the extradural. This is very important point to remember, because the aneurysms beyond this levels, if we have any aneurysms, they do not cause the subarachnoid hemorrhage. And ophthalmic artery is passes through the distal dural ring, and after that every this is the subarachnoid. This may cause a subarachnoid hemorrhage. So whole of this is the supraclinoid segment. Now the supraclinoid segment is further divided into the smaller segments, but this is just to give the names to the type of the aneurysms which are arising from these parts. So any of the aneurysm which is arising along the ophthalmic arteries, parophthalmic. Here is the posterior communicating and the anterior carotid artery. So this is the communicating segment, and then there is a terminal segment where we do not have normally any perforators, but sometimes we do have perforators, and then it terminates into two branches. The one is the ACA and the lateral branch is the MCA. So this is the end of the fairy tale with the few changes in the internal carotid artery system. So when I was preparing this lecture, I went through the lot of the segmented classification of the ICA, starting from the Fisher classification, which was developed in the 1930s, and so many other classifications. But the great Les Junias, he has developed this segmental classification, which only explains the segments of the intradural compartment of the ICA, and he does not take the anatomical landmarks. However, he take these embryological development, embryological development of the vessels as the parts. So these are the segments, for example, ILT, dorsal ophthalmic artery, then the MHT, and then the mandibular deviant. But this is only the physiological classification. It does not give us any of the edge during the surgical dissection or during the endovascular procedures. So the pathology which occur along the, most commonly along the vascular system is the aneurysm. So this is one of the example of the aneurysms, and you can see that this aneurysm is along the cavernous segment. So this is the cavernous segment, and it grows laterally, because on the medial side, it never grows on the medial side, or very few cases it grows on the medial side, because this side is usually confined by the bony attachment. And mostly the cavernous aneurysms, they do not present with a rupture, they present with the compression symptoms. I think this was the case who was presented with the third nerve palsy. So it is very important that whenever you see the aneurysm, you must know that from which segment it is arising. So the consequences and the treatment planning, surgical planning, all depends upon the site and the segment from which it is arising. This is just to tell you that while navigating with the catheters and the wires through the vascular system, one should be very careful, because it can cause the spasm and the dissection. So it should be under the roadmap all the time. So again, I want to highlight the same point, that ophthalmic artery is a very important artery. And to see the true ophthalmic originating from the siphon, we always have to see the lateral angiogram. And this is the dividing landmark between the intradural and the extradural compartment of the ICA. So this is the lateral angiogram, and this is the capillary phase, and this is the venous phase. So with reference of the ophthalmic artery, the one important point which I want to highlight here is the choroidal brush. See, this is the choroidal brush. The choroidal brush in the lateral angiogram, it is the depiction of the central retinal artery. Now, central retinal artery is not the end artery, but it behaves like the end artery. So while planning for the endovascular procedure, one should remember that if they do not care about this choroidal brush, they can cause the blindness to the patient. So the one more point I would like to highlight here is that sometimes the ophthalmic artery may show the choroidal brush from the external carotid system, and because there are the anastomosis between the ICA and the ECA, and the middle meningeal artery can also give rise to the branch, sometimes to the ophthalmic artery. So this is the diagram which I have taken from the Dr. Adnan Siddiqui's book. And again, I want to emphasize on the same point, that this is the extradural and this is the intradural compartment of the ICA, and this is the distal dural ring, and this is the ophthalmic artery. So just to make you more, feasible with this concept. This is the superior view of the orbit. So this is these are the branches. I will just want to show you the anterior and the posterior meningeal branches of the ethmoidal branch of the ophthalmic artery, because there is also the dual sleeve here. Again, this is the lateral angiogram, one of my case, and I want to show you that maybe what I do with this. So Well, here there is an anastomosis with the, so I minimize, so sorry. So the point I want to highlight is there that this is the ophthalmic artery. It is taking off from the from above the siphon, and this is the central retinal artery blush. So meaning thereby that this is the central retinal arteries here. So you can see there is some kind of the anastomosis here, and which is in the subcutaneous area. So the facial artery gives the cutaneous supply to this area. I have heard about a case few days back. A woman was having the Botox injection here, and she developed the blindness. So one should be very careful while doing some kind of the procedures here. So this is again the 3D of the left carotid artery angiograms, and this is an aneurysm which is arising from the petrous segments. And this is a very small branch of which is the caroticotympanic artery arising from here. Just to tell you about the segments of from which the different aneurysms are arising. So these are the collection of the few ICA aneurysms which I obtained from my own data. So this is the paraclinoid aneurysm. It is along the clinoid segment, and it is intradural. This is AP and the lateral view. The next is a peculiar type of the aneurysm. This is the superior hypophyseal artery aneurysms. And it is always medial and inferior, opposite to the ophthalmic artery aneurysm, which is not here, which is lateral and superior. So these kind of the aneurysms are those aneurysms which needs 3D for the proper treatment planning. So this is the lateral AP and vertebral view of the same patient. Sometimes we need all the angiograms to find out the true site of the aneurysm. So this is the dissecting type of the posterior communicating artery aneurysm. And you can see that there is another small blister type of the aneurysms in the cavernous segment. This is AP view, and this is vertebral angiogram. So between the P1 and P2 segment, here is the point from which the posterior communicating artery take off. So this aneurysm is highlighting also from this vertebral angiogram. So these are few of the specimens to show. Again, this is the cavernous segment of the ICA, and this is the distal dural ring, and then this is the intradural compartment. This is the posterior communicating artery. So distal dural ring is the dividing landmark. You must remember every time you see it that this is cavernous and this is intradural after passing the distal dural ring. So again, this is the distal dural ring, and this is the intradural compartment of the internal carotid artery. So these are the intracranial branches: ophthalmic artery, posterior communicating artery, and the anterior choroidal artery. And then this is the next segment. So with this, we move toward the external carotid artery. External carotid artery gives the direct branches in the cervical segment, and these are the lingual and the facial branches, and then we have occipital artery, and then have internal maxillary and the superficial temporal artery. So internal maxillary and the superficial temporal artery are very important because they give further terminal branches, and they also have the anastomosis. Again, these are the anterior and the posterior subgaleal branches of the STA because it gives the cutaneous supply to the scalp, and this is internal maxillary artery. Sphenopalatine, it has the anastomosis with the eye. So the point which is in reference to the external carotid artery is this, that there are always the anastomosis between the internal and the external carotid system. And though these anastomoses are not visualized during the normal carotid angiograms, but during the supraselective injections, when there is increased pressure within the feeding arteries, these anastomoses do visualize. And while doing any kind of endovascular procedure, one must be aware of these anastomoses. Otherwise, the patient would end up into the cranial nerve palsies or with the strokes. So the Pierre Lestunias was the first person who divided these territories into the functional vascular territories. So there are 3 territories. The one is the orbit, in which the connection of the ophthalmic artery is with the middle meningeal artery and through the meningeal recurrent branch, and which is the ICA and the ECA anastomosis. And then at the cervical level, there is an anastomosis between the thyrocervical and the costocervical branches with the vertebral artery, and the ascending pharyngeal artery also have the anastomosis with the vertebral artery, and then at the petrocavernous segment. I don't have time, so maybe we have another lecture on these anastomosis as well. So again, just to show you in the specimen that this is the internal jugular vein, internal carotid artery at the bifurcation. So this is external carotid artery trunk and all the branches which are arising directly from the trunk. This is posterior auricular, this is lingual, facial, and then inferior thyroidal. You always remember it with the surrounding structures. So this is the terminal branches, STA and the internal maxillary artery, and you can see the anterior and the posterior division of the STA supplying the cutaneous supply into the subgalia. So the next is the anterior cerebral artery. Anterior cerebral artery is best projected in the AP projection, and it has 4 or 5 segments. Somewhere it shows the 1 segment, and somewhere 4 segments, and somewhere the 5 segments. So the A1 segment is the pre-communicating segment, and then the A2 segment is after the anterior communicating artery takeoff. And then we have closomarginal branch and the periclosal artery. Periclosal artery is always described with along the corpus callosum. So we have A3, A4, and A5, and it finishes at the splenial part of the corpus callosum, giving the splenial artery. Now, this splenial area is important collateral anastomosis from the splenial branch of the posterior cerebral artery. And this is important sometimes when we occlude the PCA, sometimes we have, due to this anastomosis, we can save the area or the penumbra. So the A1 has the medial lenticular artery. So again, this is lateral projection of ICA, and you can see all the branches of ACA. This is A2, and then this is, let's suppose here is the corpus callosum. So here is the infracallosal at the genu of the corpus callosum, then the supracallosal, and then the posterior callosal. And this is the closomarginal branch. Closomarginal branch goes towards the medial side, and it supplies the paracentral lobule. So this is just to reinforce the same concept, because I find it very good. I have found somewhere in the at internet. So this is, again, this is A2, and this is A3, and this is supracallosal and the posterior callosal branch, and it ends up here as the splenial branch. So these are the rest of the closomarginal branches. So we always remember it with the corpus callosum. So again, to reinforce the same concept, this is the circle of the Willis, and you have A1 from both sides, and then the anterior communicating artery in the middle. So this is one of the variant in which you see that they have 3 A2s arising from the anterior communicating artery. There is also the recurrent artery of the Habener, which is very important branch, and I want to tell you that it may arises between the A1 and A2, and sometimes it arises directly from the A2. Now, this branch supplies the head of the caudate nucleus, and sometimes during the clipping or during the endovascular procedure, when you do manipulate a lot, that causes the spasm of the recurrent artery of Habener, and the patient may have developed the infarct of the caudate head of the nucleus. Again, the ICA showing the bifurcation M1 and A1 with the A2 and recurrent artery of the Habener. So this is the frontal part. It is showing the complex of A1 from both sides and A2, and then anterior communicating artery with the fenestration and aneurysm. The fenestration is very common in the anterior communicating artery, and we have always associated with the aneurysm. So this is the lateral and the AP ICA carotid angiograms, and you can see the branches of the AC very clearly here. So this is the A1 segment. A1 segment give rise to the medial lenticular artery. Here is the anterior communicating artery, which is give rise to the aneurysm. It is the commonest site of the aneurysm. Then A2, and then this is on the lateral side. This is the periclosal and the closomarginal artery. So these are a few of the examples from my own cases. So this is one of the variant in which the AC is totally absent, so it is aplastic, and you may have the aneurysm and the 2 ACs on the other side. So this is the lateral angiogram showing the branches of the ACA, anterior communicating artery aneurysms, another type of the anterior communicating artery aneurysms. Here you can see the distal AC aneurysms, which you always best see at the lateral angiograms at the A2 and A3 segment. This is the same AP and the lateral view of the same aneurysms, in which you can, same patient in which you can see the aneurysm at the A1 segment. So it is before the anterior communicating artery. It is a dissecting type of the aneurysm. This is very important that you should know from which part the aneurysm is arising, because that helps to make the treatment planning. Again, another type of the ACOM aneurysms, and this is also one of the variant in which the anterior communicating artery giving rise to 3 A2s, and there is a small aneurysm here. So the next we move to the middle cerebral artery. So the middle cerebral artery also has got the 4 segments. The first M1 segment is the sphenoidal segment, which give rise to the lateral renticustrite arteries, then the insular, and then the opercular, and then the terminal one. Now, the point is this, that the middle cerebral artery does not give the direct branch to the insula, but it hugs the insula. So it gives the perforating branches to the M2. And so the M1 occlusions, which are very common in the stroke, we always have the insular infarct. Then, so yeah, we do it here. So this is the M1 segment again with the lenticustrites. This is M2 insular segment, and then this is the sylvian segment. It hits the roof of the sylvian fissure, and then from the opercular part, which is M3, it's below the frontal operculum and above the temporal one, and then the M4, which is the terminal one. So again, the same concept, M1, this is M2, M3. M3 is the opercular, and this is the terminal one. So I just came to know that this is the early bifurcation of the M2 segment. So any of the bifurcation of the M2 which occurs if it is less than the 10 mm, then it's called the early bifurcation. Again, the branching of the MCA segments in the specimen. And this is the deep dissection of the sylvian fissure to show you the same relationships. This is the frontal lobe, temporal lobe, and this is the insula. So this is one of the case I want to show you that most of the MCA bifurcation aneurysms are broad neck aneurysms. So they are not amenable for the coiling, because one can exclude one segment or the both segments of the M2. So clipping is the best to do at the MCA bifurcation aneurysms. But this aneurysm is arising from the M1 segment. You see, this is M1 segment, and there is a small branch arising from the base, which is a lenticustrite artery. So this kind of the aneurysm, it is not treated best with the surgery. We have to perform the endovascular procedure, and of course with the with the residual neck. So we do not want to have the lenticustrite infarct. So the planning is very important. So next, again, we have few examples. So this is the trifurcation. Again, this is the small aneurysm at the bifurcation, and this is the posterior temporal artery. Posterior temporal artery is a very important artery because it saves the penumbra. Sometimes when there is M1 occlusion. Again, there is MCA bifurcation aneurysm. This is trifurcation aneurysm, trifurcation aneurysm. So the next we move to the posterior cerebral artery. Posterior cerebral artery again has 4 segments. Its P1 segment is the pre-communicating, and then it's in the interpeduncular fossa. Then P2 is the communicate after the, from here arises the posterior communicating artery, this, and then the P2 segment, which is the ambient one, and then P3 within the quadrigeminal part, and the calcarine one, which is the terminal one. So again, the segments, this is the basilar artery. The basilar artery, and this segment is the P1 segment. So it gives rise to the medial and the lateral thalmoperforators. Between the P1 and the P2, we have posterior communicating artery, and also we have the choroidal artery, because it supplies the choroidal plexus of the third ventricle, and then it runs into the quadrigeminal cistern, giving the quadrigeminal artery to the P3, and then into the calcarine, terminate by giving the calcarine branch to the VL cortex. So these are the occlusions to the PCA are very drastic, because they supply the peduncles. So we should be very careful by dealing with this area. This area is very important because it has medial and the lateral thalmoperforators. So whenever we have any kind of the prepontine hemorrhages, we should always perform the bilateral vertebral artery angiograms. Mostly the people do only one vertebral angiogram, which is not enough. So our studies complete when we do bilateral vertebral angiograms. So again, to reinforce the same concepts, this is the basilar artery. Then we have the superior cerebellar arteries, and this is the left PC, and you can see the P1 segment and then the P2 segment. And then, as told you earlier, we have posterior communicating artery arising between this and then the other branches also. The same concept here. So this is the deep dissection, and this is an interpeduncular fossa. The only one point which I want to show you here is this, that these are the thalamoperforators, and they are very important because they give supply to the brainstem. So few of the examples, as I told you earlier, that we always do the bilateral vertebral angiograms in these type of aneurysms. So this is the fusiform type of the VB aneurysms with the pica at the upper level, and the proximal is the pica, and ica is at the distal. So this is another side. So this is the superior cerebellar artery aneurysms, and there is also the variant of the double superior cerebellar artery. So this is the type of aneurysms where surgery is not possible due to the difficult skull base dissection, and here the endovascular procedure can be done. Again, superior cerebellar artery aneurysm, and then there is a prepontine hemorrhage, and you did the bilateral vertebral angiogram. You see this is the dissecting type of the aneurysm at the P1 and P2 segment. So again, this is the P1 and this is the P2. So this is the dissecting type of the aneurysm. So this is very important that you should know that there is also the occlusion of the distal PCA. Another bilateral vertebral angiograms to see the another type of the aneurysm, which is at the VB level, and here the pica is arising from here, and this is the basilar tip aneurysm. So then we come toward the vertebral artery. Vertebral artery has again the 4 segments. The first segment is extraosseous segment. It is a small segment. Then straight away it goes into the C6 transverse foramina, and it's a large segment which is called the V2, and it then exits through the C2 and up to the foramen magnum is the V3, which is again the extraspinal, and then it pierces the dura to become intradural. So this is the straightaway course of the vertebral artery. And vertebral artery give them, we have the muscular branches from the cervical segment of the vertebral artery, and then we have the pica, then we have the ica, and the basilar artery. So here we have V1 segment, V2, then V3, and V4, which is the intradural part, and both vertebral arteries from both sides then fuses in the center to form the basilar artery. This is the pica, ica, and then this is the superior cerebellar artery. Now the basilar artery have the perforators mostly at the posterior aspect, which are the pontine type of the perforators, and the other perforators also, and then at the apex we have the thalamoperforators, which are very, very important. And the most important branch we have is the anterior spinal artery, which usually arises from here. So yes, these are the 2 anterior spinal arteries which are arising from each vertebral artery, and then they unite together to form the basilar artery, and this is the anterior inferior cerebellar artery, just to reinforce the same concept. With this, I finishes my arterial system and then go towards the venous system. For the venous system of the brain, I think always consider the venous system that like a vein. Veins are like the small rivers. So because the rivers have the different kind of the tributaries, and they have the connections, and then they drain into the larger ocean. So the veins of the brain, they also have, like the rivers, they have the connection tributaries, and then they drain into the dural sinuses. So we have the superficial venous system, we have deep venous system, and then we have the dural sinuses. So this is a very simple kind of the diagram which I made showing all 3 systems. So always think about the tributaries and the connections. I'm not so good in making these diagrams, but still I try to make something for you. So we start with the superior sagittal sinus. Superior sagittal sinus begins from the foramen cecum, which is not visible here because it is only visible in the babies, and then it goes all the way down up to the torcula. And this is the 3D reconstruction of the venous angiogram, and you can see the rostral extent of the superior sagittal sinus. This is crista geli. It receives the sum of the veins from the cribriform plate, and then it goes all the way down up to the torcula. And these are the superficial venous connections going tributaries going into the superior sagittal sinus. So this is the whole extent of the superior sagittal sinus. Sometimes the rostral part of the superior sagittal sinus is not visible, and this is one of the variation. And one should know this variation because you can mistaken it as a thrombosed part, and then you may end up in disaster. So this is another variant. This is not very common. I have taken it from the lecture of Eaton Ras. This is the fenestration, and this is important for the endovascular procedures while navigating into these venous channels. So I was talking about the connections of the superior sagittal sinus. So brain has got this ability when the one part of the brain is occluded or thrombosed, the brain starts to drain from another connection. So always think whenever there is occlusion of the some part of the venous channels, there is always an alternative channels which are draining the brain. So this was the meningioma, which was sent by the neurosurgeon for pre-surgical embolization. And you can see the blush from the middle meningeal artery and superficial temporal artery, and this is the post-embolization. The point I want to highlight is there that you can see that this part of the superior sagittal sinus is occluded. So what alternative routes the brain can use to drain the brain? Brain can use the very famous vein of Labbé, and which goes into the transverse sinus, and another route is the superficial middle cerebral vein through which it drains into the anterior part of the cavernous sinus. So brain always drain from alternative channels. Then the inferior sagittal sinus. Inferior sagittal sinus, sometimes you can see, sometimes you don't see. This is again the 3D reconstruction of the venous angiogram. So this is inferior sagittal sinus. It runs under the free border of the fox, and it end up into this is the straight sinus, and it is very close to the vein of the Galen. So the other parts are, this is the deep venous system, and this is the basal vein. So this is the inferior sagittal sinus. So this is again an example, and this is, you can see the posterior part of the superior sagittal sinus is not realized here because it is thrombosed. So whenever there is a thrombosis of the posterior part of the superior sagittal sinus, there is another alternative way to drain the brain. So this is the Felsen sinus, which connects the superior sagittal sinus with the straight sinus. So then we move towards the transverse sinus. It is not uncommon to see the big right transverse sinus and the very small left transverse sinus. This is one of the variant. So again, the same figure. This is left transverse sinus. This is the right transverse sinus. And next we move on towards the tributaries of the transverse sinus. So again, the very famous vein of the Labbé, which drains the inferior part of the frontal lobe and temporal lobe, and it opens into the transverse sinus, sometimes rostrally and sometimes caudally. So we must recognize this vein. This is very important vein during the dissection also. The second tributary is the superficial middle sylvian vein. So the sylvian system is a separate system. It opens up into the anterior part of the cavernous sinus. Sometimes it finishes here, and sometimes it bypasses the cavernous sinus and it open up into the transverse sinus, and here it forms a tentorial sinus. Another point which I just see this, that this is the flat. So whenever you see the flat kind of the vein, it means it is intradural. So the another tributary of the transverse sinus is the posterior fossa veins. We are not going to touch the posterior fossa veins because it is a separate talk. So again, same, the tributaries of the transverse sinus, it's the vein of Labbé, it's the superior protorsal sinus. Here is the cavernous sinus, and this is the superficial middle sylvian vein entering into the cavernous sinus, and this is the inferior protorsal sinus into the internal jugular vein. So we must know all these tributaries. So torcula is the it's the point where the superior sagittal sinus, left and the right transverse sinus, and the straight sinus meet, and it exits through the jugular foramen into the internal jugular vein. Sometimes it also exits through the emissary veins. Emissary veins are very common in this region. There we have these occipital emissary veins, we have mastoid emissary veins, and posterior condylar emissary veins, and this sometimes when the anterior part of the superior sagittal sinus is occluded, brain uses the diaploic and the emissary veins as an alternative pathway to drain. So this is the example from one of my own case. So this is some low flow type of the vascular malformation. And you can see that it is connecting through the mesentery vein to the superior sagittal sinus. So this is the sinus pericranii. So this is the sinus pericranii. And we do not embolize this because we can embolize the normal draining venous channels. So next is the cavernous sinus. Cavernous sinus is again a very big topic, but what makes us peculiar is this, that this is a vein which contains internal cerebral artery and then third, fourth, fifth, and sixth nerves. So this is the cavernous sinus, and this faint shadow, this is the lateral angiogram, and angiogram showing the venous face, and this is the faint shadow is internal cerebral artery. So this is a double masking, and you can appreciate the relationship between the internal carotid artery and between the cavernous sinus here. And this is also one of the venous phases of one of my angiograms. And here you can see all the connections of the cavernous sinus. Here there is superior ophthalmic artery, and then there is inferior petrosal sinus, and here is this is the choroidal blush, and here there is a facial artery, and then the angular artery. So this is an amazing way to find the anatomy of the cavernous sinus. In the cavernous sinus, this is bilateral inferior petrosal sinus sampling, which we do for the pituitary microadenoma sometimes. So we have the catheters here. So these faint shadows are the ICAs, and these are the cavernous sinuses and superior and inferior ophthalmic veins, and then the inferior petrosal sinuses. So this one is from my own case. This was the paraganglioma, which was sent to me by one of the neurosurgeon for embolization. But this is not inferior petrosal sinus injection. This is the carotid angiogram, and you can see that the paragangliomas has the exclusive supply from the ascending pharyngeal artery. So it is getting supply both from the neuromeningeal trunk and from the pharyngeal trunk, and then there is a fistulous communication with all the venous cavernous sinuses. You can see both ICAs and then the cavernous sinuses and the intercavernous sinus, which is the connection of both, and the rest of the venous anatomy also. So we do not embolize this case because it ends up into the basal nerve pulses because of this, and also we can block the normal venous channels. So again, the same anatomy on this. So superficial middle sylvian vein draining into the anterior part of the cavernous sinus. So next we talk about the deep venous system. Deep venous system is a very small system, but it's a very difficult system. I try to make it simple for you. So, so to help you understand this. So yes, with this. So these are the ventricles. The components and the functional anatomy of the deep venous system are only two: internal cerebral vein and the basal vein of Rosenthal. Basal vein of Rosenthal is the part of the superficial venous system, but it makes connections with the ICV as well. So we also consider it the part of the deep venous system. So these are the ventricles. This is the head of the caudate, and this is the thalamus. So we have internal cerebral vein, which is formed by the septal vein and the thalamostriate veins. We have caudate veins, and here is the basal vein of Rosenthal. So it's the point of the convergence at the vein of the Gallen, which is a very small area, and then enters into the straight sinus. The same, this is the septal vein, thalamostriate vein, then the atrial vein, and then the occipital vein, and they converge to form the internal cerebral vein. So very few words about the deep medullary venous system and the superficial medullary veins. So how the deep system drains the brain. It drains the deep white matter and also the striatum gray matter of the basal ganglia by the deep medullary veins, and into the subependymal vein and the caudal vein. And then the superficial part drains into the superficial cortical veins. Now this gray part and the white part, all of this is drained by the deep venous system. That's why when we have the occlusions of the deep venous system, we end up into the large infarcts. So these are the tributaries of the ICVA. You need not to remember this because you forget the next day. So again, the point is this, that this is, again, I repeat, that this is internal cerebral vein, and this is the basal vein of Rosenthal, and they form here the vein of the Gallen, and then they end up into the straight sinus. So the basal vein of Rosenthal have the connection with the cavernous sinus as well. So the point is this: when we have the occlusion here into the straight sinus, still brain can drain through the basal vein of the horizontal. But when we have the occlusion or thrombosis at the internal cerebral vein, there are no other ways to drain, brain to drain, so we end up into the big infarction. They have some connection, but they are very few. So ICV is a convergent system into the vein of the Galen. Again, the drainage of the striatum into the ICV and the BVR. And this is basal vein of horizontal, and this is internal cerebral vein, making the vein of the Galen and going into the straight sinus. So one of the extreme variant of the medullary vein is the developmental venous anomaly, and which is the normal, it is the normal structure. The developmental venous anomaly is the normal dilated type of the deep medullary vein, but it's very fragile. So this is one of the case which presented with the vertigo, and you can see on the contrast there is a developmental venous anomaly with the Medusa head, lateral and AP deep delayed venous phases. You can see this anomaly, which is the developmental venous anomaly draining the normal channels. So we do not occlude the normal draining vein. However, they usually present with the thrombosis, and heparin is the treatment of this anomaly. So the superficial venous system is the system, conceptual system of the system of four. You need to remember only the four things. So this is the vein of the trolloid, posteriorly the vein of the labae, anteriorly there is a superficial middle sylvian vein draining into the cavernous sinus and the basal vein of horizontal. So sometimes you encounter with some of the variant, like this is the frontal vein. Frontal vein, this is important from the surgical point of the view, and you may find it sometimes, and sometimes you don't find it. So the point which I want to highlight here is that there is an anastomosis between all the superficial channels. So this part is, if it occluded, that is the superior sagittal sinus, the brain starts draining from the other channels, that is superficial middle sylvian vein draining into the cavernous sinus, or through the vein of the labae, which is going into the transverse sinus. So all of the system, they are interconnected with each other. So with this, I finish my venous system. And for the complete venous study, you must have both ICA angiograms and both V angiograms with the venous phases. So